Rau to talk about peritoneal carcinomatosis for colorectal cancer, cytoreduction and HIPEC.
Just now, appendiceal cancer, I think we really have to think that it's another kind of cancer than compared to colorectal cancer. Even there we separate colon cancer from rectal cancer, so I would say that we also have to do this for appendiceal cancer. It's more rare. And now I have to talk about colon cancer. We know that in peritoneal metastasis, and that is, I think is what we have to say in future. It is not anymore the peritoneal carcinomatosis which implements in our heads that this is a disease without prognosis, without nothing, we just can offer them palliative treatment. No, we cannot. We have to think about in which kind we have to put these patients, and this is a peritoneal metastasis, like liver metastasis, bone metastasis, and not carcinomatosis anymore, if possible. So I think this is important to give them a new perspective, this kind of disease. And as you can see, this for gastric cancer, we have synchronous, metachronous, solitary peritoneal metastasis. In nearly about 30–50% with standard treatment, palliative chemotherapy, this is the median survival is not more than 7 months, but if you put cytoreductive surgery and HIPEC in this patient, and especially if you have to evaluate them very good with a low PCI, we have a median survival for gastric cancer with a PCI beneath 7. We have 26 months median survival. So this is something for metastatic gastric cancer, but of course it's a worse prognosis. And this is also something which we have to think about in colorectal cancer, where we have synchronous or metachronous peritoneal metastasis. They have a better prognosis than gastric cancer. But if you put additional treatment, aggressive treatment, so possibly for these patients, we also have better results. We know that in colorectal cancer, we have lung metastasis, liver metastasis, peritoneal metastasis, of course, not carcinomatosis anymore. And you see that the lung metastasis and these disease has the best prognosis, then liver metastasis, and the peritoneal metastasis somewhere in between the last situation. But anyhow, we have to differ about, or we have to know about, that peritoneal metastasis does not mean peritoneal metastasis. We have a lot of different. We have small sizes, sticky, infiltrating. We have all over the small bowel. We have ascites and the mucinous type with a mental cake, like here, where the mental cake lies on the spleen. So if you remove this in a layer, and there is this layer we talked about in the morning, you can remove this quite easily. It costs time, but it is possible. And then you have sticky but isolated, and you have also confluentic type of peritoneal metastasis. So this is possible to remove if you get the layer, but sometimes it's infiltrating and then the prognosis is more worse. We have, as we heard already, some risk for dissemination of peritoneal metastasis. So this means that in these patients who are on risk, it is possible to think about having a second look situation in between the next year. So these are patients who probably will develop peritoneal metastasis. This is tumor perforation, isolated ovarian metastasis. It is a resection of a localized peritoneal metastasis around the primary tumor. As these are the T4 tumors. It's a positive cytology if you take it. It's the mucinous type of tumor you remove, or it is a tumor who was stenotic or bleeding. However, these are connected with a dissemination of peritoneal metastasis. And of course, if you decide to get your patients with peritoneal metastasis to surgical treatment, he has to go under the MDT board, where you have to get all these things which are written here to get into a discussion if this is the right patients for this kind of treatment. Of course, you have to do this. And as I told you, you have to have a very dedicated radiologist who know about the peritoneal staging of peritoneal metastasis. And usually we have 9 quarters, and then we have the small bowel regions where we put together, so at least we have 13 regions where you can put, then if you do it laparoscopical staging, if you put them together the lesions size, and then you put here the 1 or 2 or 3, whatever, if it is confluating, if it is only smaller than 5 millimeters together, and at least the biggest PCR you can reach for your patients is a 39. So 39, I think a patient to get to surgery should, with a PCR of 39, is not a gastric cancer, it is not a colon cancer, but it is a pseudomyxoma or a mucinous type of cancer. This could be sensible. So you have to decide whether it is non-mucinous or mucinous type of cancer, and if you are able to achieve a complete site reduction. Be in this patient. You see here the omental cake, it's covered all over with tumor situation. You see here the colon. This is infiltrating. You will get this omental cake. You only can remove with colectomy. And you also see on the small bowels, on the liver, on the peritoneal surface, you can remove it, and you can really come near to complete site reduction. It is not, I think sometimes there are some spots which you leave, but therefore you perform a peritoneal, a HIPEC procedure afterwards. And in this case, you can see here was the appendiceal cancer, and I had to remove the colon with the spleen, which is behind here, with these extraperitoneal anteroresection, and this was the disease, the appendiceal cancer filled with mucinous in this situation. And he had for lymph node metastasis in this disease. Anyhow, this patient lived. We had to do a reoperation 1 year later, and there was something on the wall, on the abdominal wall, some adhesions, and this patient lived 8 years after this procedure and had bone metastasis at the end, and died in progressive disease. So what we should achieve is the CCR0 and the CCR1, which says that there are some nodules left which are below 25 millimeters. This seems to be a complete resection, but do not leave big lesions in the abdomen just to make it a bulking surgery. This is not prognostic relevant. And as you can see here, the completeness of site reduction is important for the overall survival, demonstrated by the French group. And after a resection, we perform the HIPEC procedure. We do it closed, some do it open. Sugar Baker is doing it open, and for processing situation also in our lab, it is better for us to make it in closed procedures. The advantages of HIPEC in this situation, we think that the increase of chemotherapy uptake is more enhanced if you have it warmed up over 40-42 degrees. It enlarges the infiltration depth of chemotherapy, it increases the cytotoxicity, and it reduces the tumor growth of the tumor cells. Contraindication for cytoreductive surgery is if you do not achieve a complete resection, if you have a high risk of small bowel perforation because you have lots of nodules on the small bowel and have to make lots of stitches. So this is not a good indication. If you have distant metastasis which you cannot remove, and I think all contraindications for large general surgery. And I think what I think is very important, that you have not skilled surgeon, and if you not have a skilled team take together this patient. So this is for me very important, and this is also written in literature. You need 140 procedures to be skilled, have lower complications selection criteria in colorectal cancer. We have some literatures, and I think this is what we also see in our patients. The cutoff is something around PCI 15 to 20, where cytoreductive surgery and HIPEC is sensible to offer the patient with colorectal cancer and peritoneal metastasis. I have a cutoff of 15, and this is if I have small nodules and if it is an invasive metastasis, I would say less 15 is better than over 15. Over 15, I think these are the mucinous type of metastasis, and the cystic types, usually appendiceal cancer. And in these patients, it is also possible to reach these CCR1, but CCR0, I think, in these patients usually not possible. Also for patient selection, as I told you, definitely 20 should be the cutoff to offer the patients these kind of surgery, and you have to have limited bowel disease. And if you look on this, you can see that if a patient developed peritoneal metastasis in between 1 year after primary colorectal surgery, so the survival is not very bad, is not very good. And if you have a longer interval between primary surgery and peritoneal metastasis, then you can achieve quite good prognostic situation, and I think this is also due to the biology of the primary tumor. We have running and finished randomized trials for this kind of disease, colorectal cancer with peritoneal metastasis. Here it's the profellowship. This is what was also said, that patients who are on risk, as we told you before, patients with T4 and perforated tumors and so on, they had preoperative chemotherapy and then were randomized into a follow-up or systematic second look. We are looking for the figures, I think possibly in Paris this year in September they will offer us these figures. Then there's a very interesting trial rising up from the Dutch, ColoPEC Dutch trial is it called. This is T4 tumor perforation, but still without distant metastasis. They perform a complete cytoreduction, whatever, so the primary tumor is removed with everything what is seen. Then the patient is randomized. Some of them will get an adjuvant HIPEC as an adjuvant setting. And this HIPEC could be given in between the first 10 days or after 5 to 8 weeks. And then they get adjuvant systemic chemotherapy. And all of them were laparoscopic staged again after 18 months. So with this kind of, with this study, we can answer a lot of questions in the future. So the first is, which kind of patient will develop a peritoneal metastasis in between 18 months? Is it worthwhile to perform adjuvant HIPEC? And who's going to go for the adjuvant systemic chemotherapy? What are the answers for adjuvant treatment setting? So I think this is a very interesting and very hopeful study. Then we have the PRODIGE from the French. Was also finished, had peritoneal metastasis with colorectal cancer. They performed a complete cytoreduction, then randomized intraoperatively into HIPEC or without HIPEC. What they give us on information is that oxaliplatin as a HIPEC drug in the kind of dosage seems to have increasing intraoperative hemorrhage. This was significantly. All other things are not influenced by HIPEC. Anyhow, I didn't see these kind of postoperative complication with intraoperative hemorrhage, but I take a lower dosage of oxaliplatin. So perhaps it might be the dosage, and in future they will reduce the dosage, they told me. So to compare metastasis for colorectal cancer, liver metastasis, peritoneal metastasis, I think we can come to the end that also peritoneal metastasis might be a surgical treatment option for these kind, the same like we developed for liver metastasis. So we have the frequency of about 40 to 50%. We have a kind of a surgery, which means site-reductive surgery. We give intraperitoneal chemotherapy in this situation. We achieve a 5-year survival. It is not as high as in liver metastasis, but 40% I guess is not bad. Median overall survival is something around 50 months, but the prognostic factors are surgical selection, surgical procedure, and the PCI, and the postoperative chemotherapy. I think also what we learned in the morning is that we have different kind of cancer which we have to get in mind, so possibly we also have to look if this is also selection criteria for our patients, and this is our figure. As you see, we have a high PCI in mucinous carcinoma and the mesothelioma, and in the low adenomucinous neoplasia of the appendix, and we have a low PCI in gastric cancer and colorectal cancer to achieve this kind of long-term prognosis. So the appendix and the mesothelioma are the best results, and colorectal cancer is something in between. Together with ovarian cancer and gastric cancer has the worst prognosis, anyhow better than doing nothing. And this is our learning curve now from 2030. We started at 2008, and sometimes you get your morbidity rate here. This year was quite fine, but last year I had a 10% morbidity reoperation rate in this situation, and we reduces the number of ICU stay and hospital stay over the years. So even if you are a skilled surgical oncologist and perform something regularly, you can improve your figures. So we have to look this prognosis and morbidity. I think this is something which you can influence with training, and this is my message. You have to have a carefully PCI via laparoscopy or explorative laparotomy. Contraindications: if it is not possible to perform a CCR0 or 1 resection, and you have to discuss all your differential therapeutic considerations and have a team which is skilled. Thank you.
Thank you very much, Professor Rau. Any questions? There's one up there. Would you advise cytoreductive surgery and HIPEC in BRAF mutant patients with PC and PCI?
Difficult questions. These are the patients who are on the worst prognosis, but if it is possible to remove it, not in a 10-hour situation, but if it's just if it's on the wall, or if you have to remove the peritoneal in the upper part of the abdomen, then perhaps. But if this means that if you want to get CCR0, you have to remove the colon, the rectum, whatever, gastric, then I would say no. So PCI less than 10 usually is possible for this kind of treatment, but we have no figures. This is, I cannot tell you if this is prognostic sensible. This is, I must admit.
Okay. Any other questions? I think in the essence of time, one more question.
Yes, we know that in ESMO guidelines it's an option, the hypercapacity reduction for colorectal cancer. Do you think that we have data to change this? To change it and make it an indication, or it still should be an option the guidelines?
Well, I think we have to wait for the results of the randomized trials from the French will come, I think, in September. And if they are positive, I think we really have to think about putting HIPEC into perhaps adjuvant setting just behind our colorectal procedures. Just do it then. It's a half an hour, it's an hour procedure, extra time, but could be sensible then.
All right, thank you very much for that session.